there's so much that has been said, and I'm pretty sure, like, many of you want to just jump into the conversation. There's a lot of some interesting points and some controversial ones. So I'm going to open this up. I would suggest that we don't ask questions like we keep the discussion elevated to the level where we can really keep talking about how do we ensure choice and dignity and rights for women within the context of what's been said. Rakhi, Dinesh, and Dr. Aboli. Did I miss anybody? DJ? Sorry, I forgot your name. Shika? Yeah. Okay, please. Rakhi.
Thank you for those thoughtful comments. I have a comment and question for what Preeti said and what Geeta alluded to. From what it seems like, so far the program has been focusing on family planning, as you said, and that's not the right context, because what we've been doing as part of that program is preventing women from getting pregnant. But the idea has to be prevention of unwanted pregnancies or delaying pregnancies. So maybe that's the focus, the concept that needs to change for us when we start thinking about what we actually need to do and bring in women who are not married within the concept. To do that, what I see very different from yesterday and today is yesterday was curative. The framework that we were discussing was very curative in nature. But this today is more preventive. Absolutely. Right? When you bring it as prevention, you also bring in community in equal footing. It's no good bashing just the health provider. The fact is community and the women who come to them or couples are equal partners in this. And we haven't done that great in prevention at all in any case. But there are two prevention programs that have worked well for us. One is TT injection. Where women know when they are pregnant, I need to get this injection, whether they know what ANC means or not, but they know I need to get this injection. So we've done something very well in that, and vaccines. So there are some things that we've done well in prevention, and if we put this thing of preventing pregnancies as part of prevention and see if there are lessons to be learned from these national attempts that we can use here as prevention, would love to hear your thoughts on it.
Great.
Hello. Yeah, I have just two, three observations in terms of programmatic barriers for quality of care. So all of us keep on saying regarding these fixed day services where the doctor has to come from district hospital, medical college, to CSCs and all. But just imagine the life of this doctor. He or she has to run an OPD in the morning, go to operation theater, see the patients in the afternoon, post-operative care, see the patients at his home for the private practice, and then run for the camp in the evening at 5 o'clock. Within that time of 2 or 3 hours, how much he or he can rush in the camp, and then we keep on complaining the quality, the poor quality of interactions, sufficient time not given, the laparoscope not washed properly, whatever all. So I think that's the one reason. Why can't we have a dedicated cadre of family planning surgeons, district level, 2, 3, 4 persons who can provide the services on a regular basis? That's the one point. Second, this whole issue of district quality assurance committee, I think we have been talking about this for the last 15 years or so. It's not working. 8, 9, 10 members. Invariably, only district program manager who is in the NHM shows up for whatever the quality assurance is there. And it's all a ritual which is performed, despite the fact the Supreme Court has very clearly said DQAC minutes have to be uploaded, the members' visits and all that. But on the ground, this is really not showing up. My third issue is that the programmatic division of this limiting and spacing method users. Now, this is very artificial. So there might be a couple who don't want to have any more children, then the program would define, okay, you go for sterilization. But now we have the long-acting reversible contraceptive methods, which we can keep on using, and no, beyond 35, the fertility is very, very limited. So mostly the women would be giving birth to babies 90-95% below 35. So you have the long-acting reversible contraceptions. Incidentally, hormonal IUDs, which were very expensive earlier, Mirena and all, the prices have come down to nearly 400, 500 rupees. Why can't government think of introducing these newer hormonal contraceptives, much better, no more your functional uterine bleedings, dysfunctional uterine bleedings, and those kind of problems, and you have a long-term contraception. That has to come in the focus. I think that is something which we really need to see. And I think the point on the provider bias, we feel still that there's a huge provider bias, especially when the women come for the MTP and the providers insist on sterilization. And I was talking to some of the doctors, sir, what we can do, every year he would come again and again and again, unless we insist on sterilization, we can't keep on doing MTPs all the time. Thank you.
Thanks. Dr. Bodu. Behind you.
Thank you. Thank you once again for a very enriching panel discussion. I have two comments here. One is that particularly in family planning program, although we talk of target-free approach and all that has been tried, but still there are some targets, and that leads to the limiting the provider on the outcome rather than the processes. And Chandrasekhar touched upon the importance of processes, which is very important. And because of that, we can say that we don't know whether, especially in spacing methods, if a client has agreed for or taken a spacing method, whether they are continuing or not. And very live example I came across in one of the institutions. Suddenly the institutional delivery rate started declining, and it was people didn't understand what's happening there. Finally, when the root cause was found, it was like for the PPIUCD, because that particular state was on the top of PPIUCD insertions, absolute numbers. So suddenly they were into this that they started questioning the providers if the PPIUCD rates decrease. So then the providers had the pressure to insert the PPIUCD and not actually look into the counseling part. So suddenly in one particular facility, they came across this and they found out that because women are talking about that they insert something in this institute, and that's why we don't want to go into that institute. That was one. Second one was in the morning rounds, the doctors found out that at one postnatal bed was empty. And they couldn't find the patient. When they started looking at that, the patient was walking out of the hospital. Her attendant was, and they couldn't see the baby. And her attendant was carrying the baby in a jhola. Because if they find the woman with the baby, they would bring her back, and because they had asked her to undergo a PPIUCD insertion. So she was absconding in that way. So I think it's very, very important that we look into the processes and counseling and then see what the spacing method is. My another comment is just one
Yeah.
that when the government is the driver of public health, since yesterday I have been feeling the absence of the government in this forum.
It was deliberate,
Yeah.
Dr. Bodu, because we
Maybe if I can speak up, I didn't know that was deliberate,
Yeah.
but because there are many cross-cutting and very, very tacit issues that has being raised, and if we want to have a policy formulation, then I think the government has to be there to at least listen to all these,
Sure.
what we have to say.
Yeah, and that's the intention, is to take something and pitch it to the government. So Shikha and then John and DJ. Sorry, I forgot. Yeah. Please. I think they're in different tables right there.
So my observation / question is that when we are talking about provider biases, and also based on whatever knowledge they have, so when you look at the ASHA training module, they have that section on women's need for family planning. And if you look at the part on women who don't want any more children, so you should counsel them on sterilization or IUCD. So that I feel that kind of limits your basket of choice, because what if a woman doesn't want either? Do we know whether they are actually still getting counseled on whatever other methods are available? And again, they've mentioned based on unmarried, married, whether you want to space, post-abortion, PP, they should maybe also mention about what do you do if the woman's husband is a migrant, a non-migrant, because that obviously changes what they should use or could use based on that. So that's something I felt.
So John, DJ, Leela, and then Kasturi and Alok. Okay. No, you're getting a chance. Okay, quick. Shorter in this. Yeah, you'll come. Kasturi, I said you know. Yeah. Just look out for the mic near you.
It's a family planning. If you observe over a record, over a 10 years or from since inception, slowly the family gone away and then women replaced. We never adopted in a ground level, at an ASHA level, or at FLW level, we never adopted a family-based counseling and family planning. The moment the woman comes to the labor ward or labor room, she'll rigorously, talk about you need to insert, you need to take it. But it's supposed to start from backup. Now, like how we can bring this concept of family-based family planning, counseling at a community level, so that has a longer impact or in a future time. And then since yesterday, I'm hearing repeatedly, think from service provider point of view, Health is a subject of state. The mandatory is provide to quality of care to the women or the needy people, especially community. But nowadays, we become so tuned to the service provider. If the service provider is available between evening 4 to 5, we leave everything and then go that time only. I mean, now we need to think reversing this 360 degrees thought process from the community side, how we can bring this kind of perspectives in the community so that they start raising questions, asking about their rights, and then demanding their rights, so that the service provider also think from that lens. I think maybe some, if you can throw some kind of lights on this, that will be very helpful.
Okay, DJ.
Yeah, this is Dhananjay from Circle Foundation. I wanted to make sure that what Ravi mentioned about men is not another instance of tokenism here. And I'd love to particularly work that we funded suggests that men are key decision makers in that family planning decision. So apart from ICRW, I'd love to hear from anyone else in terms of what are actionable strategies of actually, really using the people who are making the decisions, and related to what Dhanu had mentioned, looking at the family as a whole as a unit to provide that service to.
Great. Leela, Kasturi, and Alok. Leela, there's a mic right next to you.
Yeah, you've all mentioned more on clinical methods and not so much on over-the-counter usage and behaviors. I think that is something that we would like to know more about, especially because there are a lot of methods that one can get directly from a chemist shop. And there are shelf audits that happen. Large pharmaceutical companies are involved in this. Do we have information which sort of helps us understand who those users are and what could be done? Because we're not really, when we say private sector, limited only to medical practitioners sitting in a clinic. So I'd like anyone, especially Sanjeev and Chandra, if you have any information, any additional sharing on that. Thanks.
Kasturi.
Thank you very much. Just a few observations, really, for a very enlightening panel discussion. That was really interesting. But going back to the data at the very beginning, we all know, those who've worked in health, that India has a pretty nasty legacy on women's health and especially on family planning. And it's, I suppose, quite alarming to see that some of that is still latently there, because most of the facilities were not ready for, operationally ready. There was very little counseling, and the dominant method being offered is sterilization. And we know that you've mentioned yourselves that we've had some terrible scams in the last 2 or 3 years with using those methods. I suppose my concern would be, I mean, we're monitoring everything, and I think that the issues that you brought out about including the family are absolutely essential. To monitor women who've had actually gone through some family planning processes in such district hospitals or PHCs, to see what happens afterwards when the facilities are not ready and they're going through a process, what kind of infections, what kind of illnesses that they have, so that the morbidity part comes out. So that would be really valuable. Recently, I was in a district in Bihar, and I noticed that there were about 7 women between the ages of 22 and 38 waiting for tubal ligation. They looked incredibly poor, and obviously, I mean, talking to them, the incentives issue was absolutely crucial, the money, and there were lots of questions going through my head. But the only doctor present in the hospital at the time, and who does it regularly, was an ophthalmologist.
Okay.
So that's an observation, so that was quite interesting.
Alok, and then I'm really going to just bring it back to the panel.
Yeah.
Very brief,
Yeah, I have two quick comments.
Okay.
Adding to what Poonam said on community action for health, I feel that this approach has brought together both the provider's perspective as well as client's perspective, and through public hearing, it has provided a platform to engage with each other. So what we have seen in Bihar, that issues have been resolved at the village and block level, and if grievances were not addressed at that level, these were addressed at the district level. Second point I want to make is that VHNC and RKS have a significant role in monitoring the services, but their capacity is very low. So there is a need to strengthen these community-based organizations. Thank you.
Okay, so I'm going to, okay, please, very quickly. I think it's on.
Just my question to Hemant and Chandra. I think Hemant threw some light on the challenges in the various monitoring methods and tools. Chandra also particularly threw light on the role of private sector and contribution of small and medium sized clinics to larger public health impact. Just want to understand what is the experience in terms of monitoring healthcare delivery within the private sector. I think since yesterday we've been talking about quality and monitoring quality, largely in the context of public sector. But is there any experience, if you could throw some light on what's been the experience when it comes to monitoring the quality in the private sector? I think that would be helpful. Thank you.
So I'm going to just turn it back. I don't know whether you want to answer questions or just use your 2 minutes for your overall reflections, and then we're going to close. So Geeta, starting with you, whatever your reflections are based on the overall discussion, a few points you want to emphasize.
Thank you, and thank you all for really interesting and helpful comments and for good questions. I don't know that I'm going to necessarily answer questions, but I think there are 2 or 3 issues that have come up in the discussion that are really important to highlight. One is that one of the things that has happened in this period of 20 years is a form of cherry picking. And the entire idea behind ICPD was actually to bring together all of the things that we would think of as related to reproductive health and sexual health together under a single umbrella. And the reason for that was exactly because it's not possible to cherry pick pieces of women's bodies and parts of their life cycles, or men's bodies and parts of their life cycle. Now, in the period since then, the cherry picking has been magnificent because, and it's come from different sides for different reasons, mostly to do with picking out that bit that an institution, organization, funder, agency was comfortable with and ignoring what they were not comfortable with. So what were they comfortable with? Maternal health, of course. It's motherhood and apple pie. So everybody loves maternal health. How do we talk about maternal health? So then you have maternal and, of course, child health. Then, with a little bit of difficulty, adolescent health. And what is all that? How is maternal health something that is not part of reproductive health or sexual health? As far as I know, sexuality and reproduction have something to do with maternity. So why do we pull that out separately and then call something reproductive health? I think that what this has done, similarly, family planning, separate from reproductive health, separate from maternal health, and then, of course, never mind safe abortion. Who knows where it sits? it's not family planning, it's not reproductive health, it's something else. This alphabet soup that we've created is actually a process of creating silos that make it very difficult to then reintegrate and say, what does all this have to do with the health of the people and the rights of the people, women and men, who are part of this process. So I think one of the things that we really need to look at very carefully and to start moving towards is the reintegration. Now, I think that the focus on quality of care and on disrespect and abuse, which has come out of the maternal health side, actually provides us an opportunity to do just that, to pull it all back together. Because one of the things that animated much of the family planning debates was disrespect and abuse. Long before maternal health, it was in family planning that we were talking disrespect and abuse. And I think that this, therefore, allows us exactly to bring those back together. We need to talk about how we do that. So how we bring these back together, how we reintegrate rights so that it's not just health, 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 and then rights is something that we, sort of do as an add-on somewhere. And again, I think the DNA work in maternal health allows us to bring back the rights question. So I think we do need to do that. Just a couple of other very quick points. I think it's particularly important that we bring back, in the context of accountability, the civil society engagement question on accountability. And I remember in the period immediately after ICPD, during which time India was the good guy. The Indian government delegation was very good in terms of support at ICPD for the ICPD agenda. And then we had this big meeting of all the NGOs that had been involved in the ministry, with the Joint Secretary and others who'd been very working with us. And they said, absolutely, we want NGOs to be part of this, and which services can you provide? And we said, we're not here to provide services. We're here to make sure that you do the things that you've committed yourself to do under the ICPD agenda. Now, somewhere that has also tended to slip. And between service provision and this, we have a real issue. Finally, and just my last point, is this business of men, families. Absolutely. There's a whole, if I remember right, there's a whole chapter on men and male responsibility in Cairo. Yeah. And I think that, again, it slipped and slithered into something that became, what about men? And what about men's rights? It's a little bit like asking, certainly in the context of violence against women, what about men? Well, what about men? I mean, the point is not to say that men don't have sexual and reproductive health issues or shouldn't be part of programs or shouldn't be involved. They absolutely should. But there is a fundamental issue about responsibility and of autonomy. And girls and women need autonomy in this area exactly for all of the reasons of rights that people have talked about. So we need to be very careful how we address this question of men. And families, I'm sorry, but families have been the problem in this area for a long time. And that's why it was called family planning from the beginning, because it didn't allow girls or women, adults, to have any say over their lives. And I think that we need to sort of make sure we don't lose all of that background and history as we move forward.
Thank you, Deepa.
So one thing that has come up only once today and once yesterday, which is the big elephant in the room, is incentives. and we haven't paid enough attention. I just want to highlight that they are the biggest enemy of quality, because incentives are seen, I believe, by the government as a proxy for anybody holding the government accountable on accountability. So we need a separate, we need to do research, we need to do an analysis. Why India is the only damn country that has incentives. Other countries don't have incentives for family planning, and this JSY and so on, and given the fudging of the data, mismanagement, much of it goes back as incentives back to the, as corruption to the providers. But I'll leave it at that. In terms of male involvement, you asked, is anybody working on that? You know, Ravi, I'm really looking forward to your not just saying we haven't brought, there is no NGO that is working or no program that has a gender equality, gender sensitive program. What is it that we have to do? Some of the things that came out post Cairo, and Saroj is here, Population Council did a big consultation and review of global and national strategies to engage men, involve men, and so on. The big problem that came out was there is no spousal communication. There is no autonomy. There is no, so one of the strategies we did use in Main Kuch Bhi Kar Sakti Hu, which by the way is about spacing, postponing the first child, age at marriage, sex selection, and violence against women, because that, as Geeta said, ICPD was an integral part, and she's the one who, by the way, got me into trouble. I spent all my life doing Main Kuch Bhi Kar Sakti Hu, because at an advisory council meeting, she suggested we do that, we do a serial. So Geeta, yes, yes. No. It's the best thing I think we've done in terms of behavior change and communication change. So spousal communication, rights-based, women, 8% women in just 52 episodes said we aren't talking about behavior change, we're talking about now changing social norms, had the courage to negotiate family planning with their families who were opposed to them doing family planning. So spousal communication and men realizing that it is women's autonomy and the right and not the mother-in-law. So there is, one of the outcomes of the program is interspousal communication, and with a name like that, we didn't dream, but we designed it in a way that 48% of our viewers are men, 52% women, and they have interactions. Finally, on the spacing methods.
Yeah, last point.
Yeah. Okay. On the spacing methods, what are we talking about in the public health system? There is no disaggregated data on budgets. 4% of the health budget is spent on family planning, or is supposed to be spent, of which 40% is not spent. There's an unmet need. Hello, why aren't we spending this money? But the main point that I want to make is we did an analysis of the expenditures for the Bilaspur report in 2014, for 2015. Our analysis shows that 85% of the expenditures in family planning program across the country are on sterilization, of which 65% are on those incentives, and incentives not just for the woman as compensation, for the provider who brings the woman from doctor to the nurse, everybody. That's why a woman is seen as a factory per piece. They do 100.
So really, literally,
Okay. So 13 and
don't
a half.
give data. What's the point you want to make on incentives, and then we'll pass it on. Don't.
So 1.5. No. So quality, again, of care, we can spend that money on incentives. And finally, 1.5% of the expenditures of the government is on spacing methods. So what are we talking about?
I think this is going to change, because those analyses were done when we didn't have incentives, but injectables. But I think the point is we need to monitor what's happening with budgets and look at
exactly
and do the analysis of incentives, which we are already doing. We didn't bring it into this meeting. For the rest of all of you, because we literally one point on reflection, then we should break, because we'll continue to have this conversation over lunch.
Anyway, it's a challenge to speak so much. So, yeah, I'll try to quickly address 2 or 3 points. I think Leela Caleb had asked about, are pharmacists also considered providers? And yes, they are. Apart from being providers of OTC products, we've actually seen that in the case of injectables, if the woman is familiar with the method and she's had it 3 or 4 times before, the chances that she might directly buy it from the pharmacy and either the pharmacist or a nurse in her neighborhood injects it to her. We had seen that in the private sector program. The other part is, I think there was this question on what kind of monitoring is there in the private sector, is there any experience? We have experience on that. We had extensively used the mystery client survey, and we also had a certain quality of care framework for the private sector. We saw that provider bias is as much of a problem in the private sector as it is in the public sector. And many a times it's, the doctor feels that I know what's best to be done in this case, and that's what actually leads to it. Now, the third element I'll try to talk about is the involvement of men. We actually saw that there is too much involvement of men. In the case of the joint ownership of mobile phones, the man first wants to know who's calling, why is the call for, and so on and so forth. And in terms of calls to the helpline, the incoming call, even if the call is on family planning, it's the man who calls. He first ensures that, yes, this is genuinely a helpline on family planning, and then hands over to his wife and says, okay, talk to her.
So this is male control, not responsibility. That's we see. Chandra.
Yeah, just a quick 2 things I'll answer. One is on the OTC. I think if spacing has made some progress in this country, it's all thanks to the pharmacist and the fact that it's available over the counter. And again, if you look at emergency contraceptives, the last data which I had was some 11 million doses are sold. Okay? And this is something in 2010 I had. And this actually took off when it was made into an OTC. And then people like us, we wanted that, oh no, how can it be used for anything? It should be supervised, it should be used only in emergency, all the problems, and women will take it very frequently and therefore harm themselves, all based on perception, no validity. And then we went and put a ban on advertising. We made that market for private companies to work and sell that product. When did you last see an advertising on emergency contraceptive? Because we made it difficult for them. And most private large companies no longer are interested. And now who are the ones who are actually pushing emergency contraceptives? It is only the social marketing organization. And we have actually denied this terrific product to rural and poor women by our listing. Second, same thing with medical abortion. Lancet study, Guttmacher study said 81% is medical abortions are with medical thing. The moment it moved into a combi pack in 2008, women loved it, and most of them take it over the counter. And what we have seen is that unlike the perception that, they take it and they come with huge complications, no. Data doesn't show that most of them are having their abortions pretty much, they're not coming with complication. So I think it's sometimes we ourselves in our extra care for women, I think we are probably denying them, access to these technologies.
Yeah. I mean, these are really great points, because 8 months from now, we'll have Sayana Press. Whether it will ever be there for home use or not. I mean, you're really talking about the future of family planning.
One last thing.
Sorry, I should have brought it up.
No, I think if all these things have to really make a difference, is we need to change our policies. Even today, your injectable can be injected only by, has to be prescribed first by a doctor, and only the second dose can be injected by a nurse. Okay? Same thing with medical abortion. It can be prescribed only by an OB-GYN or a abortion provider. And the same thing will happen with implants if they come in. Unless policy change and mid-level providers and can use it, it'll not make a difference.
Thank you. No going back now. Okay. Well, on reflections, Geeta and Poonam, can I have your ears too? On reflections, I think, I always feel distressed when on the name of gender, the discussion boils down to either discussing about women or men or between men and women. This entire degeneration of the gender discourse to boxes has been the problem even with that chapter, men as a partner, and even now on the name of autonomies and segregating. I tell you, the gender discourse is beyond men and women and only about women, only about men. All I'm saying this. I think that's why too much control, too much involvement of men comes, because we don't know how to address men. We're using men into the program from an instrumental perspective. So all I'm saying is that please, anybody, all of those, and if you are, Poonam, you're asking how to, Ravi, tell me the prescriptions. I'm not a doctor to give a prescription on how to work with men on the program. I'm criticizing because nobody takes gender. I'm criticizing. I'm upfront.
I think we should have this debate over lunch.
All right.
Really, because
All
we're
right.
not going to
I just
settle
wanted
it
to make
here.
my point up. I just wanted to make my point up front that the issue of gender is not addressed in the manner the construct is understood, defined, or theorized. It's all oversimplification of the gender in boxes, and it does not translate into the actions. Now, how do we do it? We could discuss that.
From the engagement from frontline worker point of view, I think between the facility and the frontline worker, always for political, bureaucratic, and technocrats, everyone working in the facility is always a glamorous compared to working at the community level. So unless we change that discourse, when we have a huge workforce in the name of ASHA and ANMs and Anganwadi workers, where we spend huge amounts year after year for a frontline worker, but then we make them accountable by giving incentives, not paying them, and on the other side spending huge money at the facility level and not making that accountable. Unless we change those dynamics, it's very difficult to actually. So for example, in a Bihar case, the eligible couple registers, which were in existence in 80s and early 90s, have disappeared. There is no eligible couple registers. And we have incentives for every quarter for ASHA worker to prepare eligible couple registers for family planning, and then there is a separate incentives for immunization. Unless we change and bring that in harmony, it's not going to change. Particularly the engagement with the frontline worker and making sure that the family planning counseling takes place either at the community level as a part of a birth preparedness or otherwise is not going to change.
Yeah, I think it always helps coming in the end. I think a lot of questions have already been answered. However, there was a comment which said family planning is prevention of unwanted pregnancies. No, I think it's more than that. It's about actually providing choice to women and men, both, actually deciding when they want to have sex, when a woman wants to get pregnant should be her decision, and what method to choose to remain in a state where she is not pregnant is again a choice that should rest with her. So therefore, I think the paradigm shift from just provision of services, well, maybe that's how it got articulated, has to completely shift to provision of choices. Somebody mentioned that, maybe there were lessons from the immunization. Absolutely, sexual pressure, completely. That's the top priority, Poonamji. It starts from there, right? Somebody mentioned that we could have lessons from the immunization program that could be incorporated in the family planning program. Believe me, if that level of unwavering attention was given to family planning, we wouldn't have been discussing it at the end of the 2 days. So I think
great.
I'll close it here.
Okay, great.
And
thank you
so
Preeti.
much.
So thank all the panelists. This was a great conversation. I'm not going to sum up because we're literally going to go into lunch. But everything that we wanted to talk about, inclusive of sex, choice, violence, consent, pleasure. Oh, we didn't say pleasure.
You didn't talk about pleasure.
We did not. But everything else was covered.
Reminded us of pleasure. We can
But
always come
yeah. But thank you so much.
Okay, so before everyone leaves, panelists, you are free to roam. So we are going to break for lunch, yes. I'm sure everyone's really hungry. But what we are going to request is that you find, maybe what we should do is have just you convene as your breakout group, because what we're going to do for the next hour and a half is to have a smaller group discussion around the issue of quality improvement frameworks. And if you are unclear as to which group you would like to go to, then we had pre-assigned you, and if you haven't seen those, I'll put it out here. But you don't have to stick to your pre-assignment. So we're going to have one subgroup which is looking at frameworks and taking stock of the discussions that we've had over the last day and a half on frameworks, and to help us sort of refine, provide feedback to Dominic. Hopefully Dominic's here somewhere, because we were going to have him. Oh, there you are. So gravitate to Dominic if you want to be in the framework subgroup, and he's going to lead a discussion to get more input and to help refine a quality improvement framework. We're going to have a measurement subgroup, and Catherine Semrau, gravitate to Catherine if you're interested in discussing measurement. I think there are a whole set of measurement-related questions. We have gathered all the questions we would like for the subgroup. If it's too big, we can split into 2 subgroups on measurement, help prioritize areas for work around measurement, so that we come out with a measurement research agenda at the end of today. And then we're going to have an innovation subgroup, and we have Seema. We were thinking of Seema and Dhananjay, DJ, the two of you helping to lead, because there was the most amount we thought of interest probably in the innovations research agenda, so we might need to split into 2. Again, there are a number of areas for innovation that have come up. In addition, we have also some interest in having a group that specifically focuses around respectful care, disrespect and abuse in care. And Michelle, gravitate to Michelle if you're interested in really zooming in on that issue specifically, and that would then entail thinking through both measurement as well as innovations. But if everyone in measurement wants to discuss respectful care, then we can split it up that way as well. Sorry?
They'll talk about what they want in the...
Yeah, really, I mean, we're not trying to over-structure this for you, but we've put out some ideas building on what we've heard over the last day and a half. But it's really up to you to actually help us prioritize what is it coming out of this meeting that we want to highlight and recommend. Note that this is a BMGF-supported gathering. So, you know, we have a representative from USAID. We have Deepa somewhere from MacArthur Foundation. Oh, yeah, before everyone leaves, the first thing to do, actually, no. Okay, fine. So when we come back, we'll do a group photo. So please don't leave.
Don't go away without the group photo.
Okay. So planning to be back at
2:15.
2:15, but that's lunch and the breakout groups? 3 o'clock. Let's reconvene at 3 o'clock. If anyone is leaving before 3 o'clock, that is, have your lunch, have your breakout group discussion, and return at 3 o'clock with what you think should be the priorities for both the measurement research and the innovations research.
Actually did only 5 out of 15 things I was supposed to do.
Suspended programs and results-based financing, you might have better recording of data because people are at least some recording, worse recording.
It could be worse.
Yeah.
There could be more reporting of data. Doesn't necessarily make it better.
Doesn't make it higher quality. What are some of the other areas people are concerned about with respect to quality of care measurements, the measurement agenda?
One of the things that I hear from all the presentations that are made since yesterday is that we tend to be looking at this in a very fragmented way. Either we already
Sorry, can you speak up?
Quality of care from a provider perspective, or we're looking at it from a consumer or the woman's perspective or patient perspective, and very rarely is there a coming together of the two. For example, even when we look at some of what do women want and what have they received today, it's coming in from the lens of the provider. It's not really from the lens of the woman per se. Right? That's one aspect. The second aspect is, okay, when we talk about what do women want, I was actually surprised by the low proportion. 1%. It's very,
reporting
very low.
what? Reporting what?
Reporting disrespect and abuse. So the answer is, who are these women that we're talking about and that we need to dive into? If there are women who are reporting disrespect or abuse, is that, or is it restricted to one or two individuals of the 8 or 20 nurses who are handling the labor on? Right? So we don't have answers to all of this. So the question that I have is, how do we look at, if we want to understand quality of care on a particular issue, how do we look at making sure we're connecting all of the dots? Who plays a role in that behavior or that activity? Whether it's coming into the institutional delivery, or whether it's the labor room, or whether it's the postnatal care. Who are all the players there? And how do we do evaluations in a comprehensive way that cover the client, cover the provider, cover the so that it gives you a very clear picture of where we could intervene and where we need to intervene.
So just to say where I summarize that is the fragmentation.
So I think the idea was have a discussion around these questions. These are just questions to answer. Maybe there are other questions and other ways we want to answer this. But what are innovations which can help us address some of the issues we've been discussing over the last couple of days, quality of care being central. And I think the expectation is also for us to kind of take 3-4 ideas. I don't know if that is something that I said. Agree on 3-4 big ideas as a group, and then none of us can
Is Navika gone? Okay, so we can start either if somebody just wants to say something, or else we can start with opening up some of these questions here.
Also, if you want to clarify anything about the format of this discussion objective, I think we should agree on that. If it's clear, then we can just...
All right, we can just start. And I know we have family planning people, we have nurse mentoring people, and facilities. So we can have topics, different topics here.
Processes. Because really what you want to get at is how does that interact with whatever you've got under processes. I think that would be just my first.
No, that's helpful.
The other thing is that, just to take a point forward, a lot of those inputs, are primarily system-driven things. So, like infrastructure, HR, procurement, supply chain. So I would understand that being more of a systems thing to get them utilized, and then you start bringing in the quality filters. So.
Which I think it's important to point out is an ongoing cycle.
Yeah, and it's an ongoing cycle.
It's not one, this looks like the input is one point in time.
No, I think.
So maybe it needs to be a circle.
It has to be a cycle, yes.
There has to be a circular way of.
And I
Between
like
the two
the
and
inherent
within the
way
two.
I'm convinced it doesn't work.
It's based on, it's like.
It's a continuous quality.
One of my questions was, I think, Geeta, you brought it up, like the whole system. So this is, it's like one facility. How do we represent a whole system in this kind of way? Like the connections at different levels of the system.
Is that intended to create some of those linkages?
Well, I guess the hope was, and I'm not, maybe it doesn't work, was that this would be a way of framing intervention focus rather than, trained and optimistic and
Continuously be asked. It shouldn't be taken for granted that it's known.
I think also there's a heavy stress on the patient and the provider. Looking at the family engagement, because they put a lot of stress on this. The families can put a lot of stress and make their lives miserable, which could in turn come to the patient. We have to unpack that.
Yes, I agree. What is the misery they are going to?
And why they're doing that?
Yeah.
What
needs to be improved, because if they worked about something and they don't know where to get that information from, like in medical colleges, as Leela was suggesting, like, it's a different culture altogether. Families are not allowed inside. If the woman goes into the labor room, there's just somewhere there just can be just only a public announcement system. Families, they're not allowed to just go in, and so they don't know what's going to happen. They always have fear of cesarean section, which can happen. So and also these contraceptives like PPI, CD can be inserted. So those kind of fears are always there in the minds of the families. So they are constantly trying to
fear of, like I remember when I was working I was staying in Bihar at a remote place, and people, much prefer to consult the local quack in the bazaar than go into a very good hospital, because the staff in the hospital are from South, so they're foreign, and then they don't really trust them. And, the whole role of trust and the relationship is very important. But they go to the quack and have a very good relationship with them.
We call them quack, they call them doctor.
Yeah, and they have doctor on there. Yeah, they have doctor on there, and they have a stethoscope, and they have a prescription pad. But the community health work I interviewed,
So why don't we respect them? Why don't we call them doctor?
Well, why don't we? I mean, I'm not sure that the medical establishment would like that to happen.
No, but that's a power. They don't go. The medical establishment.
It's not very helpful. And PM should also know how to manage. Beyond that effectiveness, they should know how to look at it. And certainly what I have to say, I'm kind of an important thought to basic care, which we wanted to do.
They are already trained, so there's a 41 days of training which happened during induction for these people. Yeah, so clearly that guy was there.
They actually can also become awareness, community witness. And I guess it's also about
the verge of bringing this two-day conversation to a close. What I'm going to request is you can stay exactly where you are, and maybe starting with Catherine in the back, who has been facilitating the measurements discussion. We had quite a gathering around the measurements issue. So we'll just have Catherine, if you can just share with us 3 to 5 priorities or issues that you've discussed.
Well, we've clearly solved the measurement agenda for the next 15 years with the number of questions that we have. But I think what we really, and I would invite colleagues to jump in, please, but one of the first pieces that we think is really important is to have a review piece on the quality of care measures that are actually out there and being used already, and whether they are valid or not, and what validation studies have shown effectiveness, and also thinking about the multiple methods and ways that we can actually do validation. The second, I think, was really focused on, we talked about this fragmentation of the measurement processes and strategies around quality of care that's happening right now, and that we have several lenses through which we are measuring quality, whether it's from the provider, the woman's experience, the community experience. And we need to make that more streamlined and approachable. And right now, it's just too broken apart. So that's an area that we think could use a lot of feedback. The third area was on the design side of how do we measure quality of care, but thinking at the very beginning, what are the kind of analyses we'd like to do at the end? So thinking about the equity measures that we need to have, or how we would stratify our analyses at the end so that we're actually doing measurement up front with all those sub-analyses in mind. The fourth is really, we need some good methods around the complications assessment and measurement. They are rare at a facility level, and so how do we actually measure better complications? And that's an area for research and more focus. And then the fifth, I think we came up with that I think the table was really excited about, is this idea about how do we measure context in a streamlined fashion that can give us insights into how context matters. Because I think that was a theme across the past 36 hours, is that context is everything, but how do we measure that, and so that we can actually inform the interventions going forward. And then on the methods area, I think we were really focusing on what is the purpose of the data that's being collected, whether it be for an HMIS and government system, or it's a program project or a research trial specifically, being really clear about what the data is being used for, and also streamlining we all spoke about the data collection methods that are out there right now, and we've got a lot of different registers, a lot of different pieces of paper that are collecting the same piece of information, and trying to streamline that more appropriately and rigorously. And then finally, there was a conversation about having a data users support group or feedback group so people can really talk about the challenges. I mean, I would love to be able to share our data collection tools from the trial and say, these are things we wish we had done really differently, and these are the things that we think worked well. And so being more open and transparent in ourselves as a community around measurement, what's working and what's not. So is that a fair summarization? Okay, thanks.
Fantastic. Thank you so much. If I could come over to DJ and Seema, to the group that has been discussing innovations for improving quality of care.
Yeah, so we discussed a number of innovations, and I'll bucket them as processes, innovations of processes, then use of technology, and some accountability mechanisms where there's inherent motivation. In terms of improving complications, there was an idea from here around a lot of deaths happening in those during transportation. So really working with, as much as we work with the nurses, but working with this the EMT stuff, the technicians would be one idea. Then in terms of some process-related best practices, quality circles, to foster continuous improvement was one idea that came up. Really having those meetings once a day, really simple, low-tech stuff, but to discuss cases that have happened once a week can then bring that culture of looking at quality and outcomes. Starting with simple things like starting with self-assessment rather than coming from the outside and telling people that everything is wrong here. Starting with self-assessment is often a good practice. I think the other perspective to take is to take the perspective of the provider who works there. So one interesting idea from the team was position what we want from the providers as something that speaks to them. So for example, for a facility which is overburdened, positioning family planning as fewer clients seem to have resonated in parts of UP. So I'll hand over to Seema, to the Seemas actually.
Yeah, I'll talk a little bit and then I'll hand it over to Dr. Seema. So in terms of, we looked at use of technology, and one of the examples that was brought up was especially in case of training, where we are training the nurses or any providers basically is creating these small videos, snippets of videos for all different training modules that people can then go back to and look at it whenever they need to do that, rather than not feeling comfortable asking questions or saying that, oh, I didn't understand that. It will be very convenient for them to just go back and refer back to that. The other thing was also, I think UP team is also using it, is creating, during training or during any processes that they're doing, is taking videos of those and then going back and looking at the videos by the providers, looking at it themselves to figure out exactly where, what they did well or what they didn't do well and how they could do it better. So they could debrief on that, and it's so much easier than trying to remember what had they done wrong, or or where, how could they improve. One more thing that came up was, in terms of tech, was the use of case sheet in UP specifically, and I'm going to hand it over to Dr. Seema to talk about that and a couple other things.
Okay, really brief, because we're really brief. We don't need the in-depth description of the innovations, just the solution set.
Yeah, solution set is, as Seema said, that about the case sheet, we are trying to do a case sheet tool so that we can have a case sheet audit. That is a clinical audit. I think everyone sitting in, it's one of the measurement things which we can do. That is in the process. But as a solution for many things which were discussed later, in UP we had started, we have discussed, I won't reiterate, that the nurse mentoring program. And we found there was that the complications were not managed in CHCs. They were identified, pre-referral management, and then they were shifted. But the women were dying during transit or in the higher facilities where they landed. So UPTSU did that solution, which I said yesterday also, pitching in doctors to involve when the complications occur in a labor room. So complications have to be managed by certain competencies. That is, in a way, CMOC services have to be used. So where doctors are also into it, because nurses can do normal delivery and some of the complications, but some things OBGYs and doctors are required. So for that, we took 50 FRUs, and we involved 4 medical colleges. And the EPIC college was KGMU. And we had 48 faculty members who were the mentors for doctors. So we had 50 FRUs with, in the first lot, 215 doctors. And I will not go into detail because a lot of work has been done in the last 8 months. And we mentored about 215 doctors who are both specialist cadre and MBBS doctors to build up their capacity. Because training and updated knowledge to manage complications is the key for anything. But with that, you have to add a component, as TSU added in the previous one, when the nurse mentor was posted in the block, on-site mentoring. So this is also here, the doctors, actually the faculty is going to the public health facilities to mentor the doctors on complications. So their capacity is being built on simulation techniques. So it's a whole program, which is no time to discuss here. And one thing which we thought was 3 things in this RRTC program. We say Regional Resource Training Center program involving faculty to train the public health doctors. It is, one thing was the capacity building of doctors, specialists, and MBBS doctors. Secondly was the referral system, which Dhananjay said. And third is the vertical integration, as Sir also said, was talking. It's always nice when you walk, you should talk also. You should discuss. People never talked. Complicated, woman died in the facility. Empathy, nobody talked about it. Now people have started talking. There is a vertical, they discuss what could have been done during meetings. That's a vertical integration, which Yerkar motivated us to do, and it's going on well with groups and all.
Great.
And
so Seema, if you can wind up, because I think we don't...
One thing I would like to suggest, one recommendation.
Please.
And because we have such an elite crowd out here.
Sure.
One suggestion, because I've not discussed with my PD this.
Okay.
My suggestion in the next steps I thought was, and I discussed with Sir, is like we are doing faculty is taking a mentoring of doctors. Can't we involve the senior nurses of those medical colleges? We are nursing college. Can't we make a team of them and go there and build on-site mentoring at the same time. This was my
That's a great
recommendation.
idea. Great idea. Thank you. So I think really rich set of innovations for us to consider. If I can move now to the back, to the breakout group that was specifically focused on respectful care, Shika.
So we had a very interesting discussion and we touched upon a lot of points, but I am going to mention the ones that we felt are the most important for now. Where we felt research is lacking is, and where there's betterment required, is communication between the different players, being between provider in the facility and provider and patients in the facility, which we felt was very important as a first step towards respectful maternal care. A second thing brought up was talking about birth preparedness from the ANC stage, where the clients have full information when they are going for a vaginal exam. They know that they can ask questions. They have an idea about why they are going for this, why is it beneficial for them. So that was the second thing we touched upon. And the third thing we touched upon was actually based on a very interesting project that Deepa told us about, where you define a role, you have a person in the health system to basically help the clients navigate the system, and that also reduces the stressors onto the family. The fourth thing that we talked about was looking beyond just the labor room, beyond just delivery, and looking at gender, power, and respect as a whole, and how all of these things, they're interlinked. And another point was looking at locally feasible mechanisms for addressing accountability, and there was a lot of very interesting talk about this. One was the use of CCTVs, that apparently some hospitals have put CCTVs in right at the entry doors, where you can, in some cases, you can hear what's going on, or you can just see what's going on if someone's actually running away with the baby. But at the table, there were some people for and against it, thinking that it's more of a punitive measure, where basically you are scaring people into actually following some form of respectful care, as compared to actually changing their behavior. And another thing that comes under this accountability was looking at, when we look at colleges and universities, or even in the institutions, how do you, if you know that one of your colleagues is actually doing something which is not big enough to maybe report, but is still something which comes under being disrespectful, how can you actually report this in a way where it's still confidential? Because I'm sure a lot of people they'd be scared about their own repercussions about being someone who's being a whistleblower. And a last point which was just added was what is actually missing in the training curriculum based on around respectful care.
Great, thank you.